Welcome back, everyone. We hope you're all ready for the afternoon session of Day 2 of the conference. Let us start with Session 7, Part 2 of the Neurology session. Please welcome our chair, Dr. Junaid.
Thank you very much. Thank you, Lillian. The people are coming, and at last, we are on the last session. I hope we put it this last session very much, intense, and the very hottest topic is the name of the conference. But this is the hottest session, and it's my pleasure to introduce the first speaker, Dr. Yusuf Kosa. He's the perinatal and neonatal neurologist. I mean, this is a very rare species, I must say, the perinatal and neonatal neurologist, okay? And he is the working in the Division of Neurology in Children's National Hospital, our other sponsor from George Washington University, USA. So he is going to talk about mechanism of prenatal brain injury and developing targeted therapies toward improving neurological outcome. And this is very important as few of our tertiary care centers doing the cooling, the total body cooling, but what else? Yusuf, please, very welcome.
Good morning. Actually, it's afternoon. It's still morning for us in the US. It's, I think, 6 a.m. right now. It's an honor and a privilege to be here. My name is Yusuf Kosa. I'm one of the rare species, a prenatal and neonatal neurologist. And with me is Dr. Sarah Schlatterer, also another rare species, a prenatal and neonatal neurologist. It's an honor and a privilege, again, to be here. What a beautiful city and what an amazingly organized conference. Thank you so much for having us, and it's a wonderful opportunity for Children's National to participate in sponsoring the conference, so thank you for the opportunity to do that. I'm going to talk with you today in this hottest topics of neonatal medicine about the future of what I see as neonatal neurology, which is to prevent brain injury. As neonatologists, you've often been the first person to diagnose a child, a neonate, with a severe brain injury from a viral or other sort of injurious agent. And at that point, it's already too late. So we have to start sooner. And I'm going to talk with you today about how we can develop models and systems to start earlier in detecting brain injury and then in preventing it. And again, I want to thank the scientific committee and the advisory board, Dr. Ayman and Dr. Junaid and the committee for really warm hospitality over the past couple of days. So thank you very much. I have no financial or non-financial relationships to disclose. And this is our roadmap of objectives during the talk. I'm going to review the spectrum of neurodevelopmental disabilities that are caused by prenatal viral infections. And the topic of today is prenatal viral infections, but lots of other teratogens, and viral infections are considered among them, lots of other teratogens cause very similar problems. And the mechanisms might be the same. We're going to explore possible unifying theories towards the ultimate goal of understanding how injury happens, and then one day developing a targeted therapy to prevent injury. And then we'll develop a system to talk about those things and advance our understanding of the prenatal brain using model systems. I'm fortunate that this talk is included today, and thank you for including it, because we talked about clinical, established evidence, established plans for clinical research, rare cases of therapies, and we've heard some examples of that today. And this talk bridges some of the basic to translational that gets us to the clinical systems and those evaluations and therapies. Virally induced prenatal brain injury is a significant problem. Upwards of 25% of pregnant women, and this was just one country, and they looked at only 2 viruses using serological testing. Upwards of 25% of pregnant women are exposed to a prenatal viral infection. And when there is an exposure, sometimes nothing happens, but sometimes a severe brain injury in the developing fetus does happen. And when that happens, we often don't have a therapy to prevent it. Actually, most of the time, we detect it after the brain injury has already happened because we use ultrasound and MRI to detect it, and that's already after cells have been injured. So we need to, again, start tuner. Despite the significance of the problem, we can't prevent the injury, and so a deeper understanding of the mechanism is necessary. And if I leave you with nothing else today, please remember this slide. And I know that you know it, but I want you to think about it in this way because it's helpful to think about it in this way. It shows the impact of the problem. Across the top, I've listed different types of viral infections. Some of these are RNA viruses, some of these are DNA viruses, some of them are transmitted by mosquitoes, others are transmitted by mice, others are transmitted by humans. And then down the first column here in green are different types of neuropathological features or neurodevelopmental delays and disabilities. And as you look across the rows, you'll see that the same type of neurodevelopmental problem can be caused by multiple unrelated viruses. And as you look down the columns, you'll find that each type of virus can cause several different types of neurodevelopmental delays and neuropathological features that are often very difficult to distinguish based on a clinical test or even an imaging pattern because there's so much overlap, and we'll talk about that too. And so, as a molecular geneticist or biologist, this to me suggests that there's a common root shared mechanism at which these things intersect. And so we're using Zika virus, and that's the virus that I'll talk about today, to study this problem, but what we learn about Zika virus might be applicable to other viral infections also. And this is the clinical spectrum that we often see. As neonatologists, you most often see the kids with the severe syndromes, the kids that are severely affected, that have hypotonia, brain malformations. Those are the kids that we see in our NICUs. But what we don't often see are the kids or the fetuses that are lost before birth. And that is a significant portion of individuals as well. And then, in addition to that, work at Children's National, among other institutions, has shown that not everybody who looks normal is developmentally normal after a prenatal viral infections. Because these things that happen to them are on a molecular or a microscopic scale. And so just because we haven't seen it, doesn't mean that a problem isn't going to happen in the future. And then a portion of kids with prenatal viral exposure are truly unaffected. And different viruses have different numbers, but the same pattern holds true. And so this is how I think about it. I think about it as a spectrum of outcomes. And so you see here a bell-shaped curve where some kids are truly unaffected. There was a prenatal viral exposure. Nothing happened to them. They were unscathed. Some kids are severely affected. These are the prenatal demises or fetal deaths here. And then most kids are going to land in the middle, where they're probably affected, but maybe until 2 years of age, they come up to a clinic for an evaluation of a developmental delay or disability. And then some other kids are also possibly affected, but they need quantitative tests to be able to tell if there's a difference in their development or not. And each of these spectrums affect each one of these neurodevelopmental delays or disabilities. For example, social development, global development, head circumference, attention, seizures, and the refractoriness of seizures, and intellectual ability or disability. And so why so much variability? Well, it's because there's a lot of modifiers. There's the virus, there's the vector, there's the host, and that's still complicated because there's the mother, placenta, and fetus, and the time point of infection. And then there's the public health infrastructure, the environment, and the community. And all of those play a role as well. And so this is my hypothesis. This is what our research program is working towards in the next 3 to 5 years, is identifying how these different viruses, unrelated, lead to the same spectrum, sometimes overlapping, sometimes difficult to tell the difference. And I think it's this type of picture, where they converge at a time point or a cell type or a mechanism that leads to then divergence based on other modifiers. Among the pathways, or among those shared mechanisms, where all of these viral infections, or most of them, interact with the developing nervous system, is a process called viral autophagy. Autophagy is a basic cellular and molecular pathway that's needed for neurons to develop and grow and become the cortex. And viruses also use autophagy to get into the cells, replicate, and if not quite exactly evaluated and stopped by a developing neuron, there will be cell death and therefore neuronal injury and therefore brain injury. And so our research program is very focused on the long-term goal of prenatal precision medicine, or prenatal neuroprecision medicine, which is identifying a cell type and a virus and a susceptibility factor, and then delivering a targeted therapy that affects a pathway to stop injury from happening in the first place. In order to work towards that goal, we need to understand something about neuronal viral clearance and survival, and then susceptibility within an individual. In this room, we're a very diverse group of people. Not everybody who is exposed to a prenatal viral infection in this room will have the same type of susceptibility, or will have a fetus who's affected in the same way. And so we need to know, am I at risk? Is my fetus at risk? Will my fetus exposed to this particular virus have injury or not? To work towards those long-term goals, we need to develop research basic translational model systems, because we can't do this in humans. And so we've identified three. There's a cell and tissue culture system, a mouse model that links prenatal and postnatal development because it's a living organism, and then a population genomics infrastructure, which identifies for us individual and populational susceptibilities. I'll give you examples of how our research program is integrating each one of these systems. And the techniques in each one of those systems are also additive and synergistic. So for example, cerebral organoids are human-derived stem cells, and so they tell us something about how a human neuron is responding to a viral infection, so on and so forth. In 2016 and 2017, we developed the Zika Genetics Consortium because this is a very big project, very, very expensive, and so we needed to work with other people. And we did that with no money at all. We collaborated with groups that were already on the ground during the Zika virus pandemic in 2016 and 17 and said, would you be interested in identifying genetic susceptibility for this viral infection? And most frequently, people said yes. As a matter of fact, I think all but one of the sites we asked said yes, because why not participate in a research study that gives you more information or adds value to the work that you're already doing? And so we collaborated with various bilateral centers, multilateral centers, including the CDC and NIH. These were projects that were already ongoing to study other things about prenatal viral infections, imaging, co-infections, urine testing, so on and so forth. But for us, it was all the same or very similar because we were studying genetic risk and susceptibility in the individual and the population. The sites collected the clinical data and the specimens, and they shared that with us. We created a data bank, a biobank, a sample tissue bank, and we used some of the DNA for whole exome sequencing, which then we can use to correlate outcome with genetic susceptibility and the type of virus that a person was infected with. Analyzing a small subset of the cohorts thus far, we've identified 2 mutations in autophagy genes that might be increasing susceptibility to virally induced brain injury. So it's consistent with our hypothesis. And I want to talk with you most today about an unexpected gene, which is called HexB, hexaminidase B. mTOR has already been known for a role in regulating autophagy in cells, so it wasn't surprising to us. So we started with the one that was a little bit counterintuitive, which is HexB. When there are 2 mutations in HexB, individuals have a disease called Sandoff disease, which is a neurodegenerative disease very similar to Tay-Sachs disease. In this particular individual, it was a heterozygous loss of function mutation. So one allele was mutated, the other allele was normal. And that individual had congenital Zika syndrome. So when this kid walked into clinic, had all the features of congenital Zika syndrome: collapsed skull, microcephaly, intracranial calcification, so on and so forth. But they also had a mutation in this gene. And so again, using our cell and tissue culture system, we use human-derived induced pluripotent stem cells. So these are cells that we can get from skin or blood or any other tissue in the human body, and we re-derive stem cells from these skin cells, and then we use those cells to create neuronal cells called neural stem cells or cerebral organoids, which are a novel model system that you'll be hearing more about in the coming months and years. Then we infect those cells and organoids with virus, and then we look at various downstream processes, including gene expression, imaging, analyses, among other analyses. And I'm showing you here the proof of principle that we can take induced pluripotent stem cells and make them into neural stem cells. And then the neural stem cells express markers or proteins that are expressed also in the developing human brain. In this case, it's a gene called nestin. And this is one of those experiments that was very exciting for us to do, because what I'm showing you here is Zika virus replication on the y-axis, and then this is a wild-type cell, a heterozygous cell, and a knockout cell at 12 hours, 24 hours, and 36 hours. So a normal individual with 2 alleles of HexB, an individual with 1 allele missing, and then an individual with 2 alleles missing. And what you can see here, there was no difference at 12 hours, but at 24 and 36 hours, when you infect these cells with the virus, the amount of virus that they produce is dramatically higher. It's okay, I can use this, but my slide went out. Okay, thank you. Is dramatically higher at 24 and 36 hours. So compare heterozygous and knockout at 24 hours. So more virus is produced in these cells compared to these cells, and more virus is produced in these cells compared to these cells. And we've since done this in organoids as well. And here are the organoids. Again, we use the same cell types, iPSCs, to make cerebral organoids. And the cells are cultured in a different way, but essentially what you get is a human-derived macrostructure, three-dimensional structure, that is a clonal cell population that then differentiates into various parts of cells that are also in the developing human brain. So here are the iPSCs. We plate those iPSCs, induced pluripotent stem cells, in a certain type of well, and then they start to attach to each other, and they grow and they grow and they grow until they have cystic structures that look like this, which we think model the early human ventricle. Just like the early human brain has a monoventricle and cortical cells and endothelial cells, so do these cerebral organoids. They also express blood vessel cells called CD, and this is marked by CD31, and then beta-3 tubulin, which is a neuronal marker. And they retain stem cell properties, including nestin, that same gene that was expressed in the neural stem cells, and the protein that's necessary for our analysis, which is mTOR. And this was also a very cool experiment, because what we did here is we infected the organoids with Zika virus. And so what happens in the human condition, humans develop microcephaly as a result of neuronal cell death and injury. And that's what we saw here as well. So this is a mock-infected organoid. These are 2 sister or sibling organoids. Here's one, here's the other. This one will be Zika infected, and this one wasn't. And so this one will retain its size at all the time points that we've evaluated, which is immediately post-infection, and then 48 hours and 96 hours after infection. And what you can see here at 48 hours post-infection, there's a dramatic reduction in the size of the organoid, mimicking the human condition. And by 96 hours, the organoid is just a clump of cells that are dying. We've looked at RNA sequencing analyses in these organoids as well, and there's an upregulation of genes that are responsible for autophagy, and that's called the PI3K-AKT signaling pathway, which sits immediately upstream of mTOR, which immediately sits upstream of HexB. We also used mice, and the reason that we used the mice is it's a developing organism. We can link prenatal brain injury to postnatal neurodevelopmental outcomes. Mice have social development, they have motor development, they have intellectual development, they have all of those things, and so we can model it in this model system. We infect the mice at a time point that is like when most humans who become infected with the virus are infected late first trimester, early second trimester. We weigh the mice, we collect tissues and evaluate those as well. And Our model, which is a humanized model, we've actually taken a gene that we know is responsible for human infection and put that gene in the mouse, replicates the same things that we see in humans who are infected with a viral infection. It actually, higher infectious doses, and that's what's shown here. So this is an uninfected control, and this is higher and higher levels of the virus. And then this is the length for crown rump. So this is a measurement of how big the embryo is. This is the placenta, and these are two measurements of the brain. And as you can see here, fetal growth is decreased with higher viral infectious doses, and brain length and measurements are also decreased with higher viral infectious doses. And finally, histological analysis has shown that, so this is a cool experiment. So this is a wild-type mouse for this gene, the HexB gene that we found in the individual. This is a wild-type embryo that's infected, and then another heterozygous embryo that's infected, and then another heterozygous embryo that's infected. And what you can see here, so this is two normal copies of the gene. This is a heterozygous, so missing one, and this is another heterozygous. And what you can see in both infected embryos at this time point is that there is thalamic injury, which leads to cerebral palsy and motor developmental delay, very similar to what we see in humans with prenatal viral infection. And so now we're back to this pathway where there's an opportunity to affect and deliver a therapy at the time point, given the virus of interest, to try to prevent developmental delays from happening and evaluate the effect that it has on brain injury. And so a quick recap. Prenatal viral infections are a common problem with a significant impact on human health. We identified prenatal viral autophagy among a small cohort of pathways as being a potential mediator in neuronal survival and therefore brain injury and therefore developmental outcomes. And then our early work is starting to show that rare genetic differences in individuals that can be modeled in cells and tissues and mice can affect susceptibility to prenatal brain injury. So I want to thank you for the time and for the opportunity to connect, and this is our growing team.
Thank you very much, Dr. Youssef. Really intriguing presentation. I was asked actually that why we have this last lectures very in-depth and complex, because people like, just finish lunch and they're ready to go home. But we intentionally do this when we put this program, Junaid and I, we actually put the best lectures at the end so people can stay with us. So I'm really impressed with a lot of people staying here, and thank you very much for sticking out with us. The next presentation is going to be as interesting. We always think about congenital heart disease. We will think about saturation and oxygen and perfusion. We don't really pay much attention to the brain. So it's a pleasure to introduce the next speaker, Dr. Sarah Slattler. And I promise her I'm not going to, massacre her name. So she's also known as Dr. Sarah from now on. She is a MD, PhD from Albert Einstein College of Medicine. And after finishing her MD and PhD degree, she decided that she wanted to do child neurology. So she joined Children's National. And currently, Dr. Sarah is a medical director of neurocardiac critical care at Children's National Hospital. She's also assistant professor in neurology and pediatric at George Washington University. She's going to talk to us about the brain care of patients with congenital heart disease from fetal period to perioperative period and beyond. Please join me welcoming Dr. Sarah.
Thank you so much for that lovely introduction, and thank you again for inviting me to come and speak with you today. I'm so excited to be here and to share this with you all. and also to talk about a topic that's very near and dear to my heart as a neurologist, and that is brain care for patients with congenital heart disease. I have nothing to disclose. I'm sorry, I'm a quiet talker. Thank you. I want to point out that for the purposes of this talk, the congenital heart disease population I'm going to be focusing on are those that have the most severe forms of congenital heart disease. So the patients that you're taking care of in the neonatal ICU as neonates who need surgery in that early first 30 days of life, okay? Congenital heart disease is a big category of diseases, and so that's what we're going to focus on, is the ones that you guys are seeing in the NICU. As I thought about how to present this talk and what I wanted to say today, although this audience is mainly taking care of our patients during the neonatal period, I think it's important for all of us, whether we're neurologists, intensivists, neonatal doctors, or regardless of what we're doing, to think about the brain across the entire spectrum of the lifetime, because these babies have factors that are impacting them from before they're born through adolescence. And so that's how I'm going to structure my talk today. By the end of this talk, I hope I will have convinced you that there's a critical need for neuromonitoring, both in the ICU setting as well as long-term for neurodevelopmental outcomes in this population. I also hope I will have convinced you that brain care can and should begin even in the prenatal period for this population. So why, as a neurologist, standing here talking to you about heart patients? We know that critical congenital heart disease care has come a long way in the last 30 to 40 years. We've increased survival in these patients dramatically through innovations in surgical techniques and bypass surgery. And it's been an amazing journey to see how that has all happened. However, as our patients grow up, it's become increasingly apparent that they don't come out completely unscathed from these surgeries. The patient population that we're talking about is the one that I've circled here, and it's become very apparent over the course of time that patients with critical congenital heart disease have significant long-term neurodevelopmental impacts related to all that they experience from the prenatal period and beyond. And while we initially wanted to blame the surgeons, people thought that these neurodevelopmental factors were mostly related to bypass surgery, recent research has shown that, in fact, these neurodevelopmental implications happen because of risk factors that begin in the fetal period and that build upon each other throughout the perioperative period in the NICU and even beyond into childhood and adolescence. And that's why my talk is named as I did. So I'm going to start with long-term follow-up because I think it's important for all of us here who take care of little babies to understand what we should be recommending to families as we discharge our patients out into the world and out into pediatric follow-up to grow up and to become adults. And there was a really nice scientific guideline that was put out by the American Heart Association back in 2012 that recommends that for all children, all infants, so anybody less than a year of age who undergoes bypass surgery, they should be receiving long-term neurodevelopmental surveillance and care until they grow up. This means that patients who are discharged from our NICUs with congenital heart disease should be receiving routine developmental surveillance and neurodevelopmental screening at their medical home. Now, depending on what your medical system is like, wherever you're from, that medical home may be something different. It may be the general pediatrician. It may be another kind of specialty provider. But what we hope is that as these patients are growing up, if they screen positive, and as soon as they screen positive for any concern for a developmental delay, that they should be referred for a more formal developmental evaluation, and that these patients should be seeing specialists and should be tested and put into programs to help maximize their neurodevelopmental potential. Now that we've gotten through that long-term follow-up, we can go back to the ICU where everybody's more comfortable and talk about what we should be thinking about for these children while they're in our care, in the neonatal ICU or in the cardiac ICU. And there are really two main things that I, as a neurologist, worry about for these children. And the first is brain injury. We know that children that have critical forms of congenital heart disease are at very high risk for brain injury. While almost all the patients that we see postoperatively have brain injury, this brain injury frequently occurs even before a patient has surgery. Approximately 40% of patients who have critical congenital heart disease have some type of brain injury before they ever go to the OR. The most common forms of brain injury in this population include white matter disease, which I'm showing here in, if I can get my pointer to work, here we go, which I'm showing here in this wonderful figure from a paper by Patrick McQuillan et al. In figures E and F, these little punctate white matter injury here, and small focal strokes, which are shown in panels A, B, C, and D in this figure. And while the most common forms of brain injury are these relatively small lesions, we know that these patients are also at high risk for having larger lesions, larger territory strokes. And that unfortunately, in a neonate, sometimes the neuro exam doesn't always show us when we have a large brain lesion, even if it's a large area of injury. I'm going to put up this table for you here. I won't make you bear with me while I read every single thing on this table, but I just want to point out again that there are multiple risk factors that occur throughout the time that we're interacting with patients and even before that affect patients' risk for brain injury. And this table is in a wonderful review that I helped co-author that just came out in Child Neuropsychology. So if you want to look at the actual paper, it's there. So what are the actual guidelines for neuroimaging in this population? And I'm sorry to say as a neurologist that we don't have any. We don't have clear consensus guidelines about who we should image, when we should image, or how we should image them. And this is because there's still some debate in the field about the prognostic value of imaging for these patients. There are some that say that, well, when patients have very small brain lesions, hopefully they'll still do okay, so why should we image them? I would argue that, and our center does image these patients, and I would argue that sometimes we can't always tell clinically in a neonate who has brain injury and who doesn't. And by the time we have a clinical symptom, we may have been delaying our treatments and therapies too long to help with long-term neurodevelopmental outcomes. There was a recent survey study done by Leon et al. That was published in Pediatric Research that evaluated 31 centers in North America that care for patients with critical forms of congenital heart disease. They surveyed these centers to find out what their standards of care are and found a lot of variation. In these North American centers, only 17% performed routine preoperative MRI for patients with congenital heart disease. Postoperative MRI as a routine test was more variable. Many centers do perform postoperative MRI, but the clinical indications vary. Some centers perform MRI on every patient that has critical heart disease that undergoes bypass within the first year of life. Some centers perform MRI only on those patients who have neurologic deficits at discharge. At Children's National, as I said, we aim to perform both pre- and postoperative MRI, as clinical neurologic deficits may lag behind what we see on brain imaging, particularly in neonates. When patients are not stable enough to travel to the scanner, obviously some of these patients are very hemodynamically unstable, we use head ultrasound, as outlined by our colleague Dr. Nicholas yesterday, as a wonderful interim test to see if we can catch any major abnormalities in the brain while we're waiting to obtain more definitive imaging. I'm going to move on now to talk about the second major problem that I, as a neurologist, worry about in these patients in the ICU, and that is seizures. Seizures are also an incredibly common problem, particularly in the post-op period for neonates with congenital heart disease. Early studies showed very variable numbers on how many patients actually had seizures postoperatively. However, in most recent studies where continuous EEG was used, we see that there's an incidence of about 10%, regardless of what center the study was done in. What is important for all of us who take care of these children to remember is that these seizures in this population are almost exclusively electrographic only, meaning that we have no clinical signs that these patients are having seizures, and the only way we'll know about it is if we do an EEG. The other thing that we should be keeping in mind is that for this population, for those 10% who have seizures, up to 62% of them present not with the occasional recurrent seizure or brief seizures, but with status epilepticus, subclinical status epilepticus. But the good news is that we know when to look for this. We know that these seizures tend to occur at the highest rate in the immediate 24 to 48 hours post-operatively. So we know when to look. And why are seizures important? Why can't we just pretend like they're not happening? Well, because these are associated with higher mortality, they're associated with brain injury, they're associated with longer ICU and hospital stays, and an increased lifetime risk of epilepsy. And the literature has also shown that seizures are associated with variable neurodevelopmental deficits. And I think that Dr. Siobhan yesterday did a very nice job of showing us that we really need to be treating seizures in neonates early and effectively. So what are the guidelines for EEG monitoring in the neonates with congenital heart disease? And luckily here we do have some clear guidelines. The American Clinical Neurophysiology Society put out guidelines in 2011 that state that infants and neonates that undergo cardiopulmonary bypass surgery should be receiving at least 24 hours of EEG monitoring postoperatively. In those guidelines, it states that continuous video EEG monitoring is the gold standard. However, we understand that continuous video EEG monitoring is not available in every center. So I would encourage anyone who doesn't have that available to consider amplitude integrated EEG. You know, Dr. Nicholas yesterday made an excellent point of showing us how useful amplitude integrated EEG can be when we don't have continuous EEG available. At Children's National, we are lucky and privileged to have the availability of continuous video EEG. And so our practice for our patients is that we monitor every neonate who undergoes bypass surgery for 48 hours postoperatively to screen for seizures so that we can intervene early and treat appropriately. I would be remiss in this talk if I didn't at least put up one slide about other modifiable risk factors in the ICU. Unfortunately, in 25 minutes, I don't have time to go into every single one of these features, but I do want to point out one that's near and dear to my own heart, and that is parental bonding and parental stress. We know that parents of infants in the ICU are under incredible amounts of stress, and that the ICU is not really an ideal venue to bond with your baby. However, parents are the ones taking these babies home. And no matter what we do as physicians, ultimately, parents have the largest impact on their baby's long-term neurodevelopmental outcomes. And so we know that maternal stress has been linked with psychosocial adjustment and behavioral disorders in children, and that postpartum parental stress is associated with social and emotional development and function. And so I would encourage us all as intensivists, as folks that are taking care of babies, that our patients aren't only our babies, but also their families, because they're integrally linked, and particularly in stressful situations in the ICU. So to summarize the ICU portion of this talk, I think we still have a lot of challenges to overcome. We have a lack of clear imaging guidelines, and the accessibility of EEG monitoring isn't universally available yet. But I do look forward to ongoing research and to see, as we grow as an international community, what we can develop and how we can agree to take care of these children. I just want to share one summary slide of what our practice is currently at Children's National, just to summarize what we've talked about thus far. As I said, we do both pre- and post-operative MRI for our children with congenital heart disease, as well as 48 hours of video EEG monitoring in the immediate post-bypass period. After discharge, our patients are enrolled in a multidisciplinary long-term neurodevelopmental screening and evaluation program, and they're followed from the time of discharge until they reach adulthood in that program, so that we can easily identify any developmental delays or deficits that come up and treat them appropriately. As I am one of the rare species, like Dr. Youssef before me, who does prenatal and neonatal neurology, I also want to make sure that we discuss the prenatal period. As neonatologist, I don't have to tell you how important the time in utero is for any child who is coming to our ICU. And this holds true for children with congenital heart disease as much as it does for preterm infants. We know that differences in brain development in congenital heart disease begin in the prenatal period. These children have altered brain metabolism, including increased lactate within their brain, indicating that these children are experiencing anaerobic metabolism in their brains from an early age. In this figure, I want to illustrate that we know that congenital heart disease brains are different than control brains, and that they have reduced brain volume by the time they're born. In this elegant study by Dr. Liparopoulos et al. That was published in 2010, their team performed serial fetal MRIs on mothers whose fetuses had congenital heart disease and mothers whose fetuses were control and normal healthy fetuses. And what they found is that over time, over the course of the third trimester, the congenital heart disease patients, which are in blue, diverge significantly in terms of their total brain volumes from the control fetuses who are in red in this picture. The bottom two panels are just showing that where the brain volume is reduced, the CSF spaces are increased to take up that volume within the skull. We also know that in congenital heart disease, not only are the brains too small, but the brains are immature. In congenital heart disease, in this study that was performed in patients that have hypoplastic left heart syndrome, this is again another fetal MRI study, serial fetal MRIs. The group looked at the gyrification index, or how folded the brain is, as well as cortical surface area to determine the maturity of the brains. And what we can see here is that again, over the course of the third trimester, fetuses with hypoplastic left heart syndrome significantly diverge from their healthy controls in their brain maturity. What this means for these infants is that although the majority of our patients with congenital heart disease are delivered at term, that they have premature brains. On average, patients with hypoplastic left heart syndrome have brains that are about 4 weeks behind in terms of their maturity compared with their gestational age. And why is this important? This is important because brain immaturity is associated with brain injury, both before and after cardiopulmonary bypass. So immature brains have more brain injury. Other things that I want to make sure that we're all thinking about as people who care for babies is understanding that prenatal diagnosis, and I'm not talking about fancy fetal MRIs, I'm talking about prenatal diagnosis of the heart lesion, actually improves, has been shown to be associated with better brain development and less preoperative brain injury. And that was shown in a nice paper by Pevandi et al. That was published in 2016. Why is this? It's probably multifactorial, but one of the things that is probably helping these babies have better outcomes is that when we know what the diagnosis is prenatally, we can start to plan delivery and we can start to think about how to manage these patients appropriately. We know that infants with congenital heart disease have better outcomes if they're delivered at greater than 38 weeks of gestational age, and we know that longer times between birth and surgery are associated with more pre- and post-op brain injury. So if we get together with our colleagues in obstetrics and with our colleagues in cardiovascular surgery to plan inductions of delivery so that our NICU team is prepared, our CV surgeons are prepared, if we plan those deliveries after a fetus is 38 weeks, but with understanding that the cardiovascular surgeon is available to perform that surgery sooner rather than later, we may be able to improve long-term outcomes for these babies. We also know that maternal stress is critical for brain development, and that mothers who experience significant prenatal stress may have fetuses with reduced hippocampal volume and infants with impaired cognitive performance. Also, maternal stress prenatally has been associated with worse 18-month Bayley of social emotional scores. And so by also supporting our pregnant mothers and helping them find appropriate resources for their mental health, we may be able to help improve brain development even before babies are born. And I think this is such a wonderful opportunity for us as an international community to think about how we can make care of our patients continuous from before they're born through the ICU time and until they grow up. And I think at our center, our thinking is that this really starts with an early, meaning prenatal diagnosis of congenital heart disease, and early multidisciplinary care. And I'm very proud to say that we've recently started a program at our hospital in which we are doing just that. So when a patient is diagnosed with certain critical forms of congenital heart disease, we offer this type of multidisciplinary care. We offer genetic counseling so that families can be tested, and we can understand whether these babies have syndromic or isolated causes of congenital heart disease, because that may have significant implications for their long-term prognosis and for other things that we may need to be aware of when the baby comes to our ICUs. We also offer prenatal neurology counseling, and you may be asking, well, why would a neurologist need to talk to a pregnant mom about heart disease? And it's because families have questions about these things. As soon as a family has had time to process that their child has heart disease and that they're going to need surgery and be very sick, the next thing they ask is, okay, but what's this going to look like when my child grows up? What kind of quality of life will my child have? And by helping families understand the risks and understand what may go well or what we're looking for and how we try to protect the brain, we can help reduce stress by reducing uncertainty and anxiety for these families. We can also help them prepare for the postnatal period. We can talk to them about the need for long-term neurodevelopmental follow-up and help empower our families to become advocates for their own children's care as they grow up. In the future, in the near future, we're also hoping to add advanced fetal MRI to our prenatal program for congenital heart disease. I showed you some fancy pictures that were done as part of a research study using volumetric studies for the brain. We're hoping that very soon we'll be able to move that from research practice to clinical practice so that we can help us understand how we can better take care of our patients' brains and what each individual is like. So to conclude this talk, I just want to show you what our current model is at Children's National of how we care for the brains of children with congenital heart disease. I won't read all of this out to you. I've said this to you in the previous slides of my talk. But this is what we are aspiring to, and we still have lots of work. There's many things left for us to work on, but this is what we're aspiring to at Children's National. And so I hope I've shown you that there is a critical need for neuromonitoring in our patients, and that brain care begins during the prenatal period. And with that, I'd like to thank my wonderful team over at Children's National and our funders, and thank you very much for sticking with us for the very last session of the conference.
So thanks a lot, as Eamon said, Dr. Sarah. Now, we're going back to not a rare species, but a very senior consultant neonatologist, Dr. Sajjad Rahman. And he's going to talk, since yesterday we are talking about the monitoring of the neurology patient, especially the EEG. But EEG is not readily available, and we heard about the early diagnosis of the seizure. So the amplitude EEG is the main thing. So Dr. Sajjad Rahman is a consultant neonatologist. He's a clinical director at Salman Al Habib Qasmi Hospital. He has an extensive work done in this regard because he is the part of Toby trial, and he is the one of the principal lead in the MacCool trial also. He did a lot of workshops regionally in our region and Pakistan on therapeutic hypothermia and AED. So he's going to talk to us how to interpret an easy guide about AED. Dr. Sajjad.
Assalamu alaikum and good afternoon. Thank you very much, Dr. Junaid Khan and Dr. Ayman, for giving me the opportunity and honor to be here with you and the opportunity to present a topic which I have been teaching for almost now 20 years, ever since we started with the research on therapeutic hypothermia 20 years ago. So there's nothing to disclose. This is just an educational presentation, which we have been using as a standard in all workshops. And we will discuss some equipments, but have no connection with any of these companies or any of the instruments. The objective of this presentation is to enable a bedside clinician in the interpretation of AEEG. So what is AEEG? It stands for Amplitude Integrated Electroencephalogram, AEEG. And this is basically a tool for the neonatologist. It's a bedside tool for the continuous monitoring of cerebral functions in the NICU. The monitor which we use to record AEEG is called the CFM, or Cerebral Function Monitor. And this is just like other bedside monitors like your pulse oximeter and the cardiac monitor. And here I have given the example of two of the common machines. This one is the single channel Olympic machine, and this is the double channel Brain's CFM. What do we use this CFM for in the NICU? The commonest use is for the diagnosis and management of neonatal hypoxic ischemic encephalopathy, particularly when we have to put the baby on therapeutic hypothermia. And nowadays, we're also using it for the progress during hypothermia and some prognostication as well. It's also used in the diagnosis and management of neonatal seizures in various other situations. And we can use it in encephalopathies other than HIE as well. This is a very old slide, but quite useful because it tells us what is the value of AEEG in selecting any kind of intervention like therapeutic hypothermia. So it's comparing what is the positive predictive value and negative predictive value of abnormal examination alone. Sorry. This is the abnormal examination alone and the abnormal AEG alone. But when we combine these together, you can see the PPV and NPV increase quite significantly. So good clinical examination along with the use of AEG is a very useful tool for the diagnosis of HIE. So what is the difference between a standard EEG, we call it SEEG or CEG or various people call it in various names, and the AEG? The standard EEG is time limited. You record it only for a short period of time, usually 30 minutes, 45 minutes, 1 hour. While AEG is used for continuous monitoring. You can monitor the brain function for many days, 3, 4, 5 days. The standard AEG is a multiple channel which can vary up to 30, 40, or 50 leads on the head, while AEG is either a single channel, which is the most commonly used, or it can be a double channel, and I'm going to show you how these are put in. Standard EEG is a tool for the neurologist and the neurophysiologist. That's not for the neonatologist to use on daily basis and interpret it, while AEG is a tool for the neonatologist. The standard EEG needs an EEG lab and a technician, while AEG is a simple bedside clinical tool. Standard EEG is quite detailed. It gives us an idea about the function of various parts of the brain very discreetly, while AEG gives overall function of the brain. As far as the recording is concerned, the standard EEG records both above and below the zero line. So it's a positive recording and a negative recording. While in AEEG, which is actually a processed EEG, and during this processing, we make it sure that the record is shown only as a positive recording. And standard EEG is a fast recording, while this is a slow recording, and I'm going to tell you the time in which it is recorded. So this is the standard EEG, and this is the AEEG. Now, basically, when we put a single channel or double channel, we actually record an EEG. But this EEG is converted into AEEG through 3 steps, a process. First is the process of filtration of the recording, during which we remove all the artifacts, muscle artifacts and blah, blah, and everything. And then the recording is rectified. As I told you, the normal EEG is recorded both above and below the 0 line. Here we rectify it and we make it only on the positive side. And then it is compressed vertically and compressed horizontally, and we're going to see that in a minute. So filtration. During this filtration, we remove all the artifacts. There is a special type of filter in the machine, and it brings the EEG signal to 2 to 15 hertz. Then this is followed by a process of rectification. And you can see here, the recording is both above and below the 0 line. Now we are going to change it gradually to only positive recording. So that's the way it is rectified. And ultimately, we get the positive recording. So it's all a processed signal, which gives only the overall function of the brain. Now, this is the recording paper. And on the recording paper, we can see that there in the beginning, in the lower part, this is the part which gives the voltage, and the x-axis gives the time. And we can see the distance between 0 to 5 and 5 to 10 is linear. And from 10 upwards, it becomes logarithmic. So the EEG is compressed so that higher amplitudes are shown in a very small area. So this is the vertical compression and how it works. So from 0 to 10, it is linear recording, and 10 to 100, it is the logarithmic recording, the 90 microvolts. Then the recording is compressed horizontally as well in terms of time. The recording is quite slow, and we record 6 centimeters per hour. And this one block is 1 centimeter. So 1, 2, 3, 4, 5, 6. So this much will be recorded in 1 hour. So you can have a full recording of 2, 3, 4, or 5 days. And the recording is, as I said, 6 centimeters per hour or 1 millimeter per minute. So it just displays the trend, what has been happening over time. So this is the way the trace looks like. This is the AEG, and this is the standard EEG. I'll just mention the electrodes. I'm not going to go into the details. Usually we use 3 types of electrodes: the hydrogel electrodes, the gold electrodes or the cup electrodes, and the needle electrodes. And this shows the placement on the head. This is the single channel EEG. We put 2 electrodes, one P3 and one on the parietal 4, P4, P3 and P4, and in the center is the reference electrode. In double channel AEG recording, we put 4 recording electrodes, C3, C4, P3, P4, and one is the reference electrode. So this is the normal recording paper, as I have mentioned, with the linear recording and the logarithmic recording. And this is the time on which it is recorded. Now, impedance is a very important aspect of this recording. Impedance means the obstruction in the transmission of the current from the neurons to the electrode. And more is the impedance, the less accurate will be the recording. and impedance increases, for example, if the electrode gets detached, so the impedance will increase. So the impedance should ideally be 0, which means the recording should be very, very good. Similarly, if there are hairs between the electrode and the skin, impedance will increase, or maybe sometimes edema of the skin will also do that. Now, how to interpret EEG once it is recorded? And this is the main topic of presentation today. The commonest way we interpret is by the pattern of the band. So it appears as a band, and we interpret the band. And there are two simple things. Band is normal or band is abnormal. And if it is band is abnormal, whether it is moderately abnormal or severely abnormal. From moderately abnormal, we mean it correlates with moderate hypoxic ischemic and encephalopathy. And severely abnormal correlates with severe hypoxic ischemic encephalopathy. So this is the band pattern. And this other thing which we see on the recording is the seizure. So let's see a few patterns. Now there are only a few rules of thumb. And it's very easy for any neonatologist, even for the trainees, and if a very good trained nurse can also interpret what is happening on the AEG on the bedside. Basically, this is a normal recording, and everything is written on the record itself. If you look on the y-axis, 0, 5, 10, 25, 50, 100, this is the voltage. It's all written there, just to say where is the voltage. And on the horizontal is the time, and you know this is 1 centimeter, 2 centimeter, 3 centimeter, and it's all known to us. Now we need to determine two things. This is the overall band. Where is the lower border of the band and where is the upper border of the band? And there are only two numbers to remember, 5 and 10. So the principle is that the lower margin must always be above 5 microvolts and the upper margin above 10 microvolts. That's all it is. That's what the normal way looks like. So lower margin is the single most important measure which we have to look into. And it should always be above the 5 microvolts. So let's see a few more patterns, and then I will show you the sleep wave cycling pattern. So normal band pattern. This is just a diagram. So in the diagram, as I showed you, we have to look on the lower margin and the upper margin. Lower margin should be above 5, and we can read that, and upper margin should be above 10, and that's what we see. The other thing is to see the evidence of sleep wave cycling, which is normal. So what happens during sleep is that the band becomes a little bit broad. When you're awake, the brain activity is a little bit more, so the band becomes narrow. It's actually the fall and rise of the lower margin. So in a normal recording, we can see that there are areas of wide recording and narrow. Wide and narrow. So quiet sleep and active sleep, and these alternate with each other. So this is called sleep wave cycling pattern. So there are broad areas, narrow areas, broad areas, and this is very normal. And these normal recording will disappear when there is encephalopathy. So the presence of sleep wave cycling is normal in a term and near term baby. We should be able to see it. And we should be able to see where is the lower margin and where is the upper margin. And this is what is showing upper margin above 10, lower margin above 5, and there is sleep wave cycling. So this is a normal recording. And this is typical normal recording. So now let's look some of the patterns which are not normal. And in a very simple way, I told there are only 2 or 3 points to remember, and we can say this is abnormal. Now, whenever we have babies with encephalopathy, and in the old days, clinically, we used to classify it SONET stage 1, stage 2, and stage 3. In stage 1, the baby has hyper-irritability, so the cerebral activity is more. But when you go to moderate encephalopathy and severe encephalopathy, the activity of the neurons starts decreasing. So they go into drowsiness and then coma. So when the activity decreases, the electrical activity of the brain will also decrease and it will be recorded. So how does then that appear? And for all practical purposes, as we all cool the babies, we know that we cool only babies with moderate and severe encephalopathy, and only those babies who are term and near term. So that's all we need to know from the day-to-day clinical practice point of view. So what happens is when the activity of the brain decreases, the first thing which happens is that the lower margin drops below 5. The upper margin will continue to stay above 10 microvolts, but the lower margin will drop. It means drop in the electrical activity of the brain. So that band, which was looking like a very nice sleep wave cycling pattern, now it looks like a continuous broad band, as it is shown in this one. So this is the diagrammatic one, and this is the way it looks like. And again, it is written over here. If you look on this side, you can see the voltage. So the lower margin is now below 5, upper stays above 10. So this is moderate encephalopathy. So this baby has moderate hypoxic ischemic encephalopathy. This is the same moderate hypoxic ischemic encephalopathy in this part of the trace. So we can see that the lower margin is here. It is below 5, upper is staying above 10. In the first part, we have a lot of seizures. And I'm going to show you a few slides how the seizures actually appear. And this is an important finding on the CFM recording. And then somebody gave phenobarbital. So as they gave phenobarb, all the electrical seizures disappeared. And when the seizure disappeared, the background electrical activity became more prominent and clear. So this baby has moderate hypoxic ischemic encephalopathy with seizures. Then how would this severely abnormal pattern appear? Now in severely abnormal pattern, not only the lower border is less than 5 microvolts, the upper one also drops. So it's a very narrow band at the bottom. So lower border is below 5, upper is below 10, and it appears like a very narrow band at the bottom of the record. As I said in the beginning, you have to remember only two numbers, 5 and 10. 5 microvolts and 10 microvolts. And then you can very easily identify. It's a very good bedside tool for everyone. Now, this is severely abnormal. And you can see the voltage is written here. I can see that the lower margin is below 5, the upper margin is below 10. So no doubt about that, and anybody can read that. So this is severely abnormal trace. This is another severely abnormal trace, and here we can see that the lower border is below 5, and the upper border, which is here, is below 10. And we have a lot of spikes appearing because of the procedure and care being given. This is also severely abnormal. You can see lower border is below 5 and the upper border is below 10. This is 25 written over here, so 10 is somewhere here. This is 10 line. So upper border is below 10. So below 5 and below 10. So this is severely abnormal trace. So this is what we call the voltage classification, which people have classically used during the pattern classification, which we have classically used in the diagnosis and management of hypoxic ischemic encephalopathy and during hypothermia therapy. There is an alternate classification, voltage classification, and this diagram was shown yesterday by Nicholas as well. And how do they correspond to each other? It's also given in this one. But again, it's the same. This is the normal trace, and these two are the abnormal trace. And in both, you can see the lower border is below 5. And these are severely abnormal traces. And in those both, you can see that the lower border is below 5 and upper border is below 10. And this is very, very severe, what you call the flat trace. Or if you take the EEG, it will be flat. There will be no electrical activity. So the brain is infarcted, or there is no electrical activity at all. Another important thing which we need to look for into on the AEG is the seizures. Seizures can happen with a normal background trace and with an abnormal background trace. So how do the seizures appear? So whenever a seizure appears, seizure is actually a burst of increased electrical activity of the brain, of the neurons. As the electrical activity increases, the trace jumps up. The lower border will jump up, and with that, the upper border will jump up. So it's an abrupt rise in the lower and upper margins, often followed by a short period of decreased amplitude. Now, as we said that the trace is compressed, time-wise as well. So the seizure must be at least 30 seconds in duration to be detected on the AEG, and must be at least 2 microvolts in amplitude, because we have already compressed the trace. So if the voltage of the seizure is less than 2 microvolts, or if the duration is less than 30 seconds, AEG will not detect the seizure. So it has a limitation. That's why we always say that whenever you suspect a problem on the AEG, we must always confirm this with the standard or CEEG. So any infant in whom AEG detects seizure should undergo standard EEG to confirm the findings. So let's see the seizure pattern. Now this is the typical pattern. If you look on the screen of the cerebral function monitor, it has got an upper part in which there is a CFM recording, and the lower part. Lower part gives the impedance, as well as you can open the EEG as well. So this is the CFM recording, and you can show it's recording normally. Lower border is above 5, upper border is above 10, so it looks like a normal recording. But then suddenly there is a rise. Lower border rises, and with that the upper border rises, and then it comes down. And that's a little bit normal, and again there are 2 episodes. So these are seizures. And how would we know this? There is a marker on the screen, usually it's green in color, and you can put it on the area which appears like a seizure and press the EEG button, and the underlying EEG will appear, and you will know that this was a seizure. So you can easily identify significant seizures on the AEEG. So this is basically a normal trace where you can see that the lower border is above 5, upper is above 10, but there are a lot of seizures over here. And this red color marker is trying to open it up, and you can see this is the recording of the seizure. And you can also see it therapeutically. For example, if you think that the baby seems like having abnormal movements, and the trace looks abnormal, and you think this could be seizure, and here it appears this is a seizure. So this baby is actually having seizure. This is a seizure, this is a seizure, this is a seizure. And here by the green marker we have opened, and we can see this is a seizure. Then what we do, give IV phenobarb. And this is a bedside test. As we give the phenobarb, the trace changes. And you can see the seizures have disappeared. So this is a sort of therapeutic test. The baby really was having electrical seizures. Whether there were mechanical seizures or motor seizures with that or not is a different issue. But at least we know the baby had electrical seizures, and they all got controlled with the phenobarbital. Again, seizures with the effect of medication in a severely abnormal trace. This baby was having a lot of seizures over here, and then somebody gave IV midazolam, and you can see the seizures disappeared, but the background trace appeared, and this baby has severe encephalopathy. Lower border is below 5, upper border is below 10. So this baby has got severe hypoxic ischemic encephalopathy with seizures. So these are continuous seizures, what you can call the status epilepticus. And seizures are so much that the trace never comes down to the bottom. They keep on going on and on and on. These other continuous seizures and an abnormal trace. If you look in the beginning of the recording, this baby had actually severe HI. The lower border is below 5, upper border is above 10. But then he suddenly started having seizures. And this went on as a status epilepticus. And these are high voltage seizures, where the seizures are so severe that the voltage is beyond the limits of the CFM recording. But if you open up the AEG recording and convert it into the background EEG over here, you can see that these are the seizure recording. Again, high voltage seizures and severely abnormal background. We can see this is the background, lower margin below 5, upper margin below 10. And then you can see the seizures. So these are my references. Thank you very much. I hope it was useful. Thank you very much. And as I said, there are only 2 or 3 things to remember. 5 microvolts and 10 microvolts, and only 3 or 4 patterns to remember. And on the bedside, you can do a lot of diagnostic and therapeutic work by using this machine. Typically, we use it in hypoxic ischemic encephalopathy, but potentially, and a number of speakers have mentioned it, you can use it in other encephalopathies. You can use it in meningitis, you can use it in metabolic encephalopathy and detecting the seizures and treating the seizures. Thank you very much. I appreciate your time. Thank you.
Thank you very much, Dr. Sajjad. So we are reaching the home stretch right now. Before people heading to the exits, I just want to remind you that save the dates for next year, inshallah. It's going to be the 13th of 13 International Conference. Hopefully it's a lucky number, 13. And it's going to be on the 29th of February and the 1st and the 2nd of March. So from 29th of February to the 3rd of March, or to the 2nd of March, that weekend. So it's going to be Thursday, Friday, Saturday. So please save the dates for next year. And for our international speakers, please start booking your tickets. So the last speaker of this session, Dr. Muhammad Adib, he's going to join us from Boston, virtually. I think it's recorded. Dr. Muhammad Adib, I met him in 2016 in Boston, and I was very impressed with his work that we start implementing his style of neuroprotection in our Tawam hospital. Dr. Nusrat, remember this. So he's director of neonatal neurocritical care in Brigham Women Hospital in Boston, and he's associate professor of pediatrics at Harvard University, or Harvard Medical School. He is worked extensively on providing standardized, focused, integrated care for babies with high risk of brain injury. Dr. Muhammad Adib have a numerous publication on a topic, and he's a founder of Neonatal Neurocritical Care Special Interest Group that's available. You probably received some of their emails. He's going to talk to us about treatment of HIE beyond cooling. So we'll see if Dr. Adib presentation ready.
Assalamu alaikum. Good afternoon, everyone. First, I would like to thank the organizers for this kind invitation. It is my pleasure to talk to you today about the topic of management of HIE beyond cooling. My objectives today are summarizing current evidence of the efficacy of therapeutic hypothermia for hypoxic ischemic encephalopathy, understanding the limitations of therapeutic hypothermia, appreciating the value of systemic management during hypothermia, reviewing clinical trials for new neuroprotective agents. Hypoxic ischemic encephalopathy affects 1 to 3 per thousand live births in developed countries and is associated with significant mortality as well as childhood disability. Hypoxic ischemic brain injury is followed by a cascade of events. This graph demonstrates in a very simplified way how hypoxic ischemic injury leads to necrotic and apoptotic neuronal cell death. Ischemia leads to energy failure and failure of the ATP-dependent sodium-potassium pump. If the insult is very severe, the acute result is sodium influx followed by chloride and water influx, cell swelling, and cell lysis. This leads to cell death by necrosis. However, in the majority of time, less severe insult is followed by more delayed cell death, mediated by extracellular accumulation of excitatory amino acids, glutamate, and intracytosolic accumulation of calcium. This is associated with a process of oxidation, inflammation, and initiation of apoptosis, leading to delayed neuronal death, and this process takes many hours, and because of this latent phase, there are always opportunities for neuroprotection. Hypothermia is believed to be beneficial via interfering with the mechanism of injury at multiple levels. It reduces cerebral metabolism and energy utilization. It decreases excitotoxic amino acid accumulation. It inhibits nitric oxide synthase and suppress free radical activity. It inhibits platelet activating factor and inflammatory cascade, and it inhibits the process of apoptosis. The current evidence of the efficacy of hypothermia is that it reduces the combined outcome of mortality or major neurodevelopmental disability for babies with moderate to severe encephalopathy at 18 months of age from 61% to 46%. That means that there is a reduction of about 15% of poor outcome, and the number needed to treat is about 7. Also, we know it is a safe treatment, so the complications that were associated with hypothermia in the randomized trials were sinus bradycardia, which is a physiologic phenomenon, as well as low platelet counts without significant bleeding. While randomized controlled trials have shown significant reduction of adverse outcomes, almost 50% of those with moderate to severe HIE had adverse outcome. In addition, the use of therapeutic hypothermia has not been proven to be effective in low to middle income countries, mild neonatal encephalopathy, and preterm infants with neonatal encephalopathy. For low to middle income countries, the HELIX study was published in 2021. In that randomized trial, the use of hypothermia in low to middle income countries showed no difference in the primary outcome of death or disability at 2 years of age. In addition, they noted higher mortality in the control group. There are different hypotheses for these results. One of them is that babies had more prolonged hypoxic ischemic injury than acute sentinel events at birth. When it comes to mild encephalopathy, these babies have not been included in the initial clinical trials for hypothermia. So there are really no clinical trials to prove or disprove efficacy of hypothermia in this population. We discussed that controversy in a paper that was published in 2019. While many centers only cool babies with moderate to severe encephalopathy, at our center we deliberately include a proportion of those with mild encephalopathy. The rationale for that are a significant percentage of babies with mild encephalopathy and to have injury on brain MRI and to have poor outcome. And unfortunately, the biomarkers we have to identify those at risk, like the neuro exam or AEG, are not perfect. It's also quite physiologically plausible that hypothermia is neuroprotective in babies with mild encephalopathy, and it is safe. In addition, medico-legal implications of missing a case with a brain injury are grave. And when parents are asked about if they're willing to cool their babies with mild encephalopathy, most parents agree on that. However, I am also excited to see ongoing clinical trials to study this problem. So in Stanford, Sonia Bonifacio is recruiting mild NE babies in the TIME study, where infants with mild NE are randomized to cooling or no cooling. At the same time, Lena Chalak in Texas was able to recruit a large number of centers in what's called the Cool Prime study. This is an observational study that's looking at the effects of hypothermia versus usual care on 2 years outcome. In addition, we just heard about a new study that's funded in UK to study the effect of hypothermia on babies with mild encephalopathy. Finally, when it comes to preterm infants, a few weeks ago and during PAS, the preliminary analysis of the NRN study titled Randomized Trial for Targeted Temperature Management with Whole Body Hypothermia for Moderate and Severe Encephalopathy in Preterm Infants 33 to 35 week gestation was announced. Of note, that study used what's called a Bayesian analysis, which was predefined as a probability that the hypothesis is true based on observed data. The outcome they looked at was death or moderate to severe disability at 18 to 22 months. The preliminary analysis shown during PAS meeting has demonstrated that there was no difference in death or disability or death alone. However, using the Bayesian analysis, there was a probability of death or disability 53%, and the probability of treatment harming babies by increased mortality was 77%. Of note, at our center, at the Brigham and Women's Hospital, we have been cooling babies 34 to 35 weeks for many years. Also during PAS, Dr. Kim, who is a fellow working with me, presented a poster showing 20 infants who received hypothermia at gestation age of 34 to 35 weeks and compared them to 40 infants born at 36 or more gestation age. And what we demonstrated in this poster was that there was no significant increase in any of the complications, including mortality in babies born at 34 and 35 weeks when they receive hypothermia. While hypothermia has not changed much over the last decade, of note, the outcome of infants receiving hypothermia for encephalopathy has improved over the years. This nice comparison was presented by Dr. Sita Shankaran that can show that between two randomized trials 12 years apart, the overall death and disability as well as other outcomes has significantly improved. One explanation for why the outcome of these babies has improved over the years is the ability to manage these babies more appropriately. This slide is from a paper that was recently published by Dr. Wintermark, Bonifacio, and Muhammad that demonstrate all the proper care that babies receiving hypothermia should receive. I will point to some of these variables in the coming few slides. So things that can help optimization of management during hypothermia include early start of cooling, including during transport, proper respiratory management, holding infants during hypothermia, providing proper nutrition, seizures management, and the effect of having a specialized neurocritical care unit. We know from multiple studies, including the one in front of you from Marianne Thorson, that time is brain, and in these slides you can see that babies who were cooled less than 3 hours when compared to those cooled after 3 hours tend to have better outcome. For that reason, it's important to try to provide hypothermia even during transport. And there are many studies that have shown that baby active cooling during transport are more likely to arrive to the cooling center within target limits. A very important topic that I love to talk about is respiratory management during hypothermia. As we know that asphyxia can cause effects on the respiratory system, and hypothermia also can have its own effect on the respiratory system. In addition, hyperoxia can be inducing brain injury as well as hypocarbia. So really a very delicate management of the respiratory system is warranted in these cases. We and others have demonstrated that low CO2 in these babies is associated with brain injury on MRI. And we demonstrated that there was a positive association between the hours spent in the hypocarbic range and the total MRI score. And we also noted that MRI score increased by 6% for each extra hour spent in the hypocapnic range in those with moderate to severe encephalopathy. So our recommendations are to intubate only if indicated, to correct blood gas for baby's temperature, to maintain normal carbia, to maintain normal oxygenation, and manage respiratory comorbidities as appropriate, regardless of the baby's being cooled. Another factor that has evolved over time is allowing parents to hold babies during hypothermia. This was shown to be a feasible intervention associated with trend towards improved physiologic responses from the baby, and more importantly, was associated with better parent well-being. In addition, providing proper nutrition is very important for these babies. Usually we start them on TPN on admission, and we actually start some enteral feeds during the cooling process. And it seems that feeding during hypothermia is becoming more popular and could be associated with some improved outcomes. We know that HIE is the most common cause of neonatal seizures. And looking at preclinical and clinical data, we know that seizures following hypoxia ischemia may result in additional damage to the baby's brain, irrespective of original injury. In infants with HIE receiving hypothermia, injury on MRI is associated with electrographic seizure activity regardless of the initial clinical severity. Treating electrographic seizures with or without accompanying clinical signs reduces the seizure burden, and decreased electrographic seizure activity is associated with improved long-term outcomes. That's why you need to have all these babies on continuous EEG or AEG during the period of hypothermia as well as rewarming. Also, over the years, it became more and more clear that these babies don't need to be maintained on anti-seizure medications at home. In 2021, Dr. Hannah Glass demonstrated among 303 infants with acute symptomatic seizures that there was no difference in functional neurodevelopment or epilepsy at the age of 2 years in children whose anti-seizure medication was discontinued versus maintained at hospital discharge after resolution of acute symptomatic seizures. Finally, in order to take proper care of infants with neonatal encephalopathy, you better provide this care through specialized centers who see a good number of these babies and have very standardized protocols taking care of them. Of interest that some states, like the state of California, has published certain minimal requirements for centers to be able to provide hypothermia. In summary, it might not be just cooling, but the full array of complex, multidisciplinary care that makes an impact. While clearly hypothermia cannot be the full answer, many neuroprotectors have been tested over the years. I put this abbreviated list to include important ones either tried or soon to be tried on humans. This is what is called cooling plus. One of the most popular neuroprotector is erythropoietin. EPO is a glycoprotein which has low blood-brain barrier permeability, which increases in the setting of hypoxia ischemia. EPO and its receptor EPOR upregulates following hypoxia ischemia in neurons, astrocytes, oligodendroglea, microglia, and endothelial cells. The neuroprotective role of EPO is not understood. However, we know that it reduces excitotoxic cell injury, it increases antioxidant activities, and has anti-inflammatory properties, as well as anti-apoptotic. More importantly, EPO enhances neurogenesis, angiogenesis, and oligodendrogenesis, and it promotes long-term repair and plasticity. After a promising phase 2 trial, phase 3 trial called HEAL trial was completed and published just a few months ago. Unfortunately, the use of EPO in moderate to severe HIE was not associated with improved outcome, as shown in this figure, and potentially associated with more serious adverse events. Another agent that is very promising is melatonin. It is an endogenous endolamine primarily produced by pineal body from serotonin. Melatonin freely crosses the blood-brain barrier. It has an antioxidant, anti-inflammatory, and anti-apoptotic properties. I am proud that I did the analysis and co-authored one of the first human randomized controlled trial using melatonin with hypothermia, which was done back in Egypt. 13 units with moderate to severe NE were randomized either to receive hypothermia only or hypothermia and melatonin. In that study, melatonin was given enterally by NG tube and hypothermia was provided by eyes. Biomarkers were checked as baseline and at day 5, including melatonin, SOD, and NO. When the outcome of both groups were compared, 11 of the hypothermia group survived compared to 14 in the hypothermia melatonin group. These babies had MRI at 2 weeks of life and similar rates of basal ganglia thalamic injury, but melatonin group had less white matter injury. This cohort was only followed up to 6 months of age and had a neuro exam and the Denver Developmental Screening Test. More babies had normal outcome at 6 months in the melatonin group. Umbilical cord blood is rich in mononuclear cells which are able to move to concentrate around site of injury. Although these cells do cell replacement, they eventually produce a parachroidal effect through suppression of astroglial cell activation and decreased expression in the pro-inflammatory cytokines. And very importantly, they stimulate the endogenous neurogenesis, neuronal survival, expression of neurotrophic factors, and neovascularization and angiogenesis. In a phase 1 open-label, single-site feasibility and safety study done in Duke University, Mike Cotton reported in 2014 that autologous cord blood transfusion in patients receiving hypothermia was feasible. When these babies were followed up to 1 year of age, 72% had a normal outcome, compared to only 41% for those who received hypothermia only during the study period. A multi-center randomized trial was started and Brigham and Women's Hospital was a study site. Cord blood from those suspected to have hypoxia ischemia was collected. If parents consent and babies were randomized to receive plasma and red cell reduced cord blood as a study product versus diluted cord blood as placebo. The plan was to enroll 160 patients, but after 3 years, only 36 babies were enrolled, and sponsoring foundation stopped funding it. However, I think this area of stem cell therapy is very promising. There are already 15 randomized trials currently registered and ongoing. Finally, I would like to talk about a promising synthetic peptide called RLS0071. This peptide is a potent antioxidant and it inhibits complement activation and is a potent inhibitor of innate neutrophil-mediated inflammatory processes. When used in neonatal HIE rat pups Vanucci model, the use of RLS0071 alone and in combination with hypothermia was neuroprotective. RLS0071 has shown to be safe in adults clinical trials. Now I am the site PI of this study that we hope to start enrollment soon, and this is a phase 2 two-stage randomized double-blind placebo-controlled multiple ascending dose study to evaluate the safety, tolerability, pharmacokinetics, preliminary efficacy of RLS0071 In newborns with moderate to severe hypoxic ischemic encephalopathy undergoing therapeutic hypothermia with long-term follow-up. In conclusion, therapeutic hypothermia is very effective but has limitations in certain populations. The day-to-day management during hypothermia could have an impact on neurodevelopmental outcome. Promising clinical trials are underway and hold hope for the future. Thank you everyone for listening. Please reach out directly to my email if you have questions, and please check the Newborn Brain Society and check the website, and please consider to be a member. Thank you and have a good day.
The voice a little bit as it is coming from the Boston, but if somebody needs a recording, that's the thing. For the last session, I will ask the speakers to come here. I will ask Eric, I will ask Heidi to come here also. Dr. Faisal, if you can join the speakers for some question. Nicholas, if you can join. Dr. Ayman, if you can also come. We can stand here, and if any of the audience have any questions regarding this session or any other question with all these eminent speakers, please ask. Otherwise, I will start my list of questions, because there are many people have a lot of questions. Dr. Sajjad, yes, please. So come. We will stand, Eric and Natalie. So, yes, Dr. Arif, you have questions? Please come. Oh, ladies first. Yes. Please tell to whom you are asking the question.
Yes, I want to ask for the Sarah question. It is nice to see that we started thinking about neuroprotection and neuromonitoring for the baby for congenital heart disease, that we are not always thinking about heart and hemodynamics. I want to ask you, what is your experience, and are you using maybe NIRS for the monitoring baby with congenital heart disease?
Yes, thank you. That's a really excellent question. And yes, we do actually use NIRS at our hospital to monitor all the babies with congenital heart disease. We use both a renal NIRS and a cerebral NIRS. I think the difficulty with NIRS is that it can be really hard to interpret in a baby that's hypoxic at baseline when we should be intervening based solely on a NIRS. So right now we don't do most of our interventions based solely on NIRS, but on additional clinical factors. We do use that as a part of our overall clinical picture of the baby, if that makes sense.
Okay. Yeah, Dr. Aldeeb is also online. Very welcome, and thank you very much for your talk. There are some questions about that. Dr. Arif, please.
First of all, thank you so much for those wonderful talks. My question is for Dr. Yusuf. You mentioned something interesting, that the mTOR pathway can be involved in prenatal brain injury related to viruses. Do you think there's a potential role of mTOR inhibitors in the future?
Great question. So that's actually what we're working on now, is we're trying to put together the number of individuals that have loss of function, susceptibility mutations in genes along that pathway, and identifying modulators of mTOR to affect viral processing. It's an interesting question, because there's data that, this is all cellular-based data, model-based work, but depending on the time point of viral infection, post-infection, neuronal survival, mTOR is activated or inhibited, and autophagy is activated or inhibited at different ways in that process. So that's why it was important and one of the reasons that I wanted to show the 12, 24, and 36 hours, there's data from other viral infections, including dengue, among others, that mTOR can both be an inhibitory and an activator of autophagy. And so we have to find out the combination of cell type, time point, and virus. But we know that the cell type and we know the relative time point in gestation that leads to greater susceptibility. And there's other pathways too, cytokine signaling, interleukins, among others, that are also key kind of integrated points between.
I'll just ask one more question, and it could be for any of the neonatologists. We have controversies regarding treatment of mild HIE. Sometimes we recommend cooling, you have clinical criteria, CERNAT, and all that stuff. But if we don't cool them, what are the drawbacks of that? And, to Dr. Deep, he mentioned melatonin, but they are all compared along with hypothermia. So would there be a potential role of what we think is a benign agent, melatonin, in these mild HIE cases?
Sure. I direct this question to Dr. Deep. Dr. Deep, there's a question about the mild HIE.
Yeah,
So, and in addition to that question, please comment on 34, 35 weeker, because we are in this part of the world, we are not cooling those babies. Dr. Deep.
Yeah, thank you for the question. I think, as I mentioned, the treatment of mild encephalopathy is a big controversy. The bottom line is, for hypothermia, it was never really tested in the randomized controlled trial in mild encephalopathy. So it's really, that's what you call absence of evidence, but really this is not evidence of absence of efficacy. So we are left with a situation that when you have a baby that clear event prenatally who shows encephalopathy that doesn't reach moderate to severe, and what we definitely know that these babies have high risk of brain injury and poor outcome. I think that's really a difficult question. We decided in our unit to put very clear criteria. It's not like there's no variation in practice here. We put very strict criteria to babies with mild encephalopathy who are severe enough that we think that potentially this treatment can help. The idea is the preclinical data shows that hypothermia should be efficient in these babies, and eventually it could be more effective than moderate to severe babies. But the always question is, does the risks outweigh the benefits or the opposite? So without randomized trial, it's very hard to do that. So again, it's very controversial, but my only advice, it shouldn't be a blanket statement. If you are cooling mild encephalopathy, you need to put very clear criteria. What proportion of mild encephalopathy you're worried more about? And again, we are doing this, and until we have more evidence, I think it's reasonable to do that because we don't have very good biomarkers. And if you just rely on your exam and AEG, there's a lot of potential to miss babies that eventually will have injury. And I think the question for late return babies is even more difficult because I did share the preliminary data that was shared during PAS. I think we should always wait for the final publication that's peer-reviewed to understand the exact full results, understand the limitations, and understand this statistical analysis that we're seeing these days. So this type of Bayesian analysis is something I personally trying to get used to because it's not the traditional way of doing risk ratio or adjusted risk ratio. You're using really a small sample size to understand the direction of benefit or harm. So I would rather wait until we have this publication out to have better understanding what it means. Meanwhile, as I mentioned, we have been cooling 34 and 35 weeks. If their weight is above 1,800 grams for the last 10 years. And we really didn't see any difference. But again, this is anecdotal data that showed that really didn't see a big difference between them and at 35 6 weeks, for example.
Okay, thank you. Yes, ma'am, you have a question?
Yes, thanks. My question is for Dr. Heidi, and thank you very much for your very informative session on your study and your point trial and your toolkit that's actually being taken out at this moment. I'd like to actually find out about all the parameters of your toolkit that you mentioned, about the pre-med, about the interventions that's done, and how it's been phased out and rolled out as such. Are these data points, are they integrated into a, I'm going to say, an electronic database? Because some of them can actually overlap, and as you were saying about certain disruptors as such, that your next study can actually allude to, you know, for example, you mentioned about videoscopy and observation. So where exactly is all the data? Is it in the electronic database? Are you observing? So that's what I'd like to find out about.
So some of the data, so the NEAR for NEO's data is, that's all registry data that's self-reported by all of the sites and then is in a central REDCap database. So that information is all in the NEAR for NEO's database, and it's actually something that people can submit potential studies or other observational studies to answer specific questions to. You submit a proposal and then you can get access to that data. That is primarily just all the registry data. The other data in terms of the data that we have from videos, things like that, those are all housed pretty much just me. I house it and I have it, most of it in an electronic database as well. We still have, depending on the study, sometimes we keep the videos longer, sometimes we don't. But so yes, all of that is all in electronic database, just the video data is just housed with me for the time being. I am working with collaborators in Australia. They have a bunch of videos too, but it's very hard to share videos. And from a legal standpoint, people are very proprietary about those for obvious reasons. I do have colleagues that are actively working on ways to de-identify the videos so that we can have a shared database so that we can actually be able to look at these things across lots of sites. And that's part of why I'm trying to do the Verify study as well, which is a multi-center collaborative, but all of that data will be, the videos will stay at each of the sites, but the data will be entered into a central site, sort of all the information from the video. I hope that answers your question.
No, it does. Do you mind if I ask you one follow-up?
Of course.
So your toolkit that is being used on a day-to-day basis, is this in an electronic medical record format or
yeah.
I'm going to say paper-based, so that it can have criteria that it can be met and sort of almost KPI set against that as well?
Yeah, so in our NICU right now, it's on paper right now, and it's not actually part of the medical record. It's separate from that. One of my colleagues, Dr. Nishisaki, is doing work in the PICU at CHOP, working on getting it into the electronic medical record so that you can start to leverage aspects of the electronic medical record so that there's less work on the bedside providers, and also so that it's an alert in our, we use EPIC, that comes up in EPIC that this patient has an airway bundle, these are the risk factors and things. So there is work being done on that, and he actually just got some funding to do that as well. So I think that's where it will go, but for the time being, it's just hanging at the bedside.
Thank you very much.
Yeah.
Have a lovely day.
Dr. Faisal?
Yes, I'd like to ask Eric a question yesterday about a topic you mentioned, and I said I need to talk to actually discuss that with you. Regarding use of probiotic. Probiotic is the most studied topic in neonatology and least used. But do you think it's the time maybe just to let it go? Because I know you said we should come back to it. Because I think the question is that we need to concentrate on more things really, you know, hand hygiene, you know, breastfeeding things. These are going to make, really we know just 100% makes a difference to, you know, to NIC. Because I just feel that people still thinking that that's going to be maybe the holy grail that's going to make a difference to neonatology. Maybe there's a place for it, but you said we don't know exactly how to use it. And I'm not sure, maybe it's the time just to put it on the side and concentrate something else.
No, I think that's a very good question because I think there's enormous variability across the globe on how probiotics are being used. I think that in Canada, for example, I think they're being used very frequently across the Canadian NICUs, but they have a product that's a pharmaceutical grade product. And I think that that's the big question that we have in the United States. We don't have a pharmaceutical grade product, and so you don't really know what you're getting, and you don't know what the shelf life is going to be. And so that's part of the concern is that in the absence of a controlled product, you sort of don't know what you're giving. I think that the other question about whether there are specific combinations of probiotics which are better than others, whether you may choose a probiotic that has absolutely no effect because we don't know that the organism is probably important. So I think there are a lot of unanswered questions. That being said, I think that there has not been a safety concern. So I think if you decide as a NICU medical director that you want to move in that direction, I think what I would be sure of is that you've taken care of all those other things that I outlined as far as breast milk, feeding plan, use of antibiotics, not using acid blockade, and being sure that you've optimized everything before you introduce probiotics. Probiotics are probably not going to be a cure for necrotizing enterocolitis. I think the other thing that's interesting is that no study as of yet has demonstrated that probiotics are effective in the babies who are most susceptible to NEC. And I think that that information alone should empower investigators to do a large randomized trial in that population using maybe one or two different probiotics to see if there is an effect of one versus another. And I think there's more information to come. But you're absolutely correct. It's been studied probably more than any other quote-unquote medication in neonatology, but there still remains uncertainty about what to do. And so I do think that it becomes, and that's why I entitled my talk, Yes, No, or Maybe. My answer is maybe. If you've got the right circumstances, you know what probiotic you're giving, and you're following your patients and even looking at it before and after to see whether or not you've had any benefit.
But we didn't learn our lesson from the 1990s with postnatal steroid, where we're using it a lot, and then we discover it's harmful. So I feel 2,400 infants, extreme premature babies, in the ProPrem and the PIPs would have already answered the question that you need to be careful.
Well, although, as I pointed out, those two studies had opposed results. One worked and decreased the incidence of NEC, and the other had no effect. And perhaps that was because they chose different probiotic preparations. We don't know the answer to that. It may have been other factors in the NICUs that were involved in those studies. But the telling thing to me were those two observational studies that I presented, which were identical, and they showed completely different results, which I think tells you that different NICUs have different practices, are going to have different results with probiotics. And in one NICU, it may work wonderfully, and in another NICU, it may not work at all. And so we don't know what factors go into one unit having a good effect and one unit having no effect. And again, that being said, there has not been any harm that's been demonstrated, although I always worry that as we change the microbiome, whether there's going to be other long-term effects that we're not looking at currently. So there's a lot of unanswered questions, which is why I think there's so much variability across the world with the use of probiotics. In the United States, it's probably 25–40% of NICUs are using them, and the others are not.
Thank you.
Okay, just because of the time constraint, I have a WhatsApp a lot of questions which I directed to all of you, but anybody can answer, or maybe different units doing different. The very common question they ask, acetaminophen versus brufen if you have to close the PDA. It started from Nick. Which medicine you are using?
Ibuprofen. Can you hear me? Yeah. Ibuprofen is first line, and then paracetamol if there's concern about the gut.
Okay. Jensen? In your unit, acetaminophen versus brufen, to close the PDA, which medicine you are using, if you have to close it?
We predominantly use ibuprofen.
Ibuprofen. Dr. Eric Akenwald?
Well, all the CHOP people work in the same unit, but actually in the United States there are drug shortages, so sometimes ibuprofen is not available.
Yeah.
Sometimes indomethacin is not available, and so we use whatever is available, but I think most of our practitioners use ibuprofen.
Sure.
Unless there's concern for the gut or concern for the kidneys. So there are babies that do get acetaminophen as a first-line therapy. So I think we've got, I think, complete equipoise as to which drug may be better than the other, and so I think there is some variability, but I think ibuprofen, when it's available, is the first choice.
Okay. There's one more question about because Dr. Eric Akenwald, your talk is about something else, but people get confused. Urine culture you should take in late onset sepsis after 3 days of life.
That what?
Urine culture. Urine
culture. Oh, yes. I think that for late onset sepsis evaluations, you should do a urine culture.
Yes,
but it should be done sterilely, right? It should be a cath culture or a bladder tap and not a clean catch. It should be done.
So with that, thank you all, and that's it from my side, unless Ayman has to say. Thank you, Dr. Deeb from Harvard and from Boston, and thank you, all of you. We have to have a group photo. If you stay, Dr. Deeb, like this, we can have you in your group photo. Okay? So we will have it, and this is the end of our conference. Dr. Ayman already announced the date, the first weekend of the March, inshallah. We will see you next time. Please come and join. Ali, Faisal, please come and join for have our